Great, thank you. And I'd like to thank Dr. Shah for the invitation to participate today. As a radiation oncologist, I'm excited to be at this excellent conference, and I'm learning a lot. So today I'm going to talk about updates and controversies in the area of radiotherapy for breast cancer. I have no disclosures to report. Okay, so in the last couple of years, the most challenging and controversial area for radiation oncologists who treat breast cancer has been management of the regional nodes. And there have been several publications that have really made us rethink how we're designing our radiation treatment fields and what we should be including. So today I'm going to go over how we approach patients with a positive sentinel lymph node who do not undergo an axillary node dissection, and discuss the ICAHO, Z11, and Ambrose data, as well as the results of the MA20 and EITC 22922 data supporting the use of regional nodal irradiation in patients who have had an axillary lymph node dissection, but previously were deemed to be of lower risk, so those with 1 to 3 involved nodes or even node-negative patients. Internal mammary nodal irradiation continues to be an area of controversy, and there are 2 recent publications that have confused us even further. And finally, in patients who have an involved lymph node treated with neoadjuvant chemotherapy, particularly in those who achieve a pathologic complete response. I had some cases, but I'll probably get to those at the end because I think I rearranged the slides the wrong way. But one of the things that we've seen recently is a lot of patients coming to us with an involved sentinel lymph node without a completion node dissection. And this has been increasingly common since the publication of the American College of Surgical Oncology Group Z11 trial. This is a trial that enrolled patients with clinically node-negative breast cancer who were undergoing breast-conserving surgery, and if they had no more than 2 involved sentinel lymph nodes, they were randomized to a completion axillary node dissection, which was the standard of care, versus no further surgery, really testing the question as to whether or not these patients with lower volume nodal disease can avoid the morbidity of a completion node dissection. And I'll point out, and I'll discuss this a little later, that the protocol, and again, it's from the surgical oncology group, but the protocol specified that patients were to have received whole breast radiotherapy alone. And I'll get back to that in a second. So the patient characteristics were evenly distributed, and it represented a very favorable patient population. So most patients had small tumors that were ER positive, and over 95% of them received some form of systemic therapy. I'll also note that in the group that had a completion node dissection, 27% had residual nodal disease found at the time of surgery. So we can assume that the other group with the sentinel lymph node only surgery would have had similar results. And that's important when we think about designing our radiation treatment fields. At a median follow-up of a little over 6 years, there was no statistically significant difference in the local or axillary recurrences. And not surprisingly, no difference in disease-free or overall survival. So the authors of this study concluded that in patients who had no more than 2 involved sentinel lymph nodes, as long as they were in theory undergoing whole breast radiotherapy after breast-conserving surgery, could safely omit a completion node dissection without impacting outcomes. Yet at the same time, as I mentioned, this was a surgical oncology group, and so while they might have said whole breast radiotherapy alone, radiation oncologists were curious as to what radiation oncologists were thinking when it was not a blinded study, when they knew that a patient had node-positive disease but didn't have a completion node dissection. Did it actually alter the radiation treatment fields? So Reshma Jagsi and Bruce Hafty, radiation oncologists, pulled the radiation records of these patients. Unfortunately, they weren't able to get all of the patients, but of the patients that they were able to review, they found that only 80% of the patients actually received what the protocol had specified, that is, treatment to the breast only. And of those, half of them had what we term high tangents. You can see in that middle panel here, high tangents basically indicates that we increase or raise the superior border of our field closer to the humeral head in order to try to treat the level 1, level 2 axilla. And so clearly, radiation oncologists were thinking a little bit differently as to whether or not to cover more of the undissected axilla. In addition, almost 20% of the patients received a directed field at the level 3 axilla, or the infraclavicular region, and the supraclavicular region. So it was protocol deviations, but we don't really know how this impacted outcomes. There's no difference between the arms, but the median follow-up of 6 years, I think, is still a little bit early, certainly raising questions as to how we approach such patients. The Ambrose trial was very similarly designed, including node-negative patients, or clinically node-negative patients, who underwent surgery and sentinel lymph node procedure, and they were also randomized to either completion node dissection, or in this case, they pre-specified the radiation therapy field. So they included axillary radiation, which was all levels of the axilla, level 1, 2, and 3, as well as the supraclavicular field. And very similar to the Z11 trial, the patient population was fairly favorable with small tumors, most of whom received some form of systemic therapy. And again, very similarly, about a third of the patients in the axillary node dissection arm had residual nodal disease at the time of surgery. They also reported the results with a little over 6-year median follow-up and no statistically significant difference in axillary recurrence, disease-free, or overall survival. But what was striking in this trial is that at 5 years, there was double the risk of lymphedema, and 23% in the group of women who had axillary node dissection versus 11% in those who had axillary radiotherapy. So again, the authors supported no axillary node dissection in this patient with low volume nodal involvement, as long as in this trial, radiotherapy was added. Again, no difference in disease-free or overall survival, which we wouldn't expect in this low-risk group over a short median follow-up. So this is just to kind of illustrate the two trials together, and I wanted to point out the enrollment. So this was in the early 2000s, and certainly systemic therapy has changed over time with the introduction of trastuzumab in 2005 for the adjuvant treatment, as well as changes in endocrine therapy. And also, as I mentioned, a very favorable patient population, and then for our consideration when designing treatment fields, thinking about the risk of residual nodal disease in a patient who may have otherwise gone to surgery but didn't. And then finally, the size of the metastatic disease, I think, is important as well, with over about 60% of patients in both trials having macrometastatic disease, defined as over 2 millimeters, and micrometastatic disease as 0.2 to 2 millimeters in about 30 to 40% of the patients. Of note that in the Ambrose trial, I was kind of struck by this, that about 10% of patients had isolated tumor cells, so that was less than 0.2 millimeters. And in this group of patients, which is technically node negative, one might argue that you probably don't need an axillary node dissection, but you may not need full comprehensive axillary and supraclavicular radiotherapy either. And also what's also striking is both of these trials had similar outcomes in disease-free and overall survival. So suggesting from each of these trials that we can safely omit axillary node dissection in patients with low volume nodal disease. And we know that it decreases morbidity, both with respect to lymphedema risk, as noted in the Ambrose trial, and also in patients that many of you have seen where they have a lot of shoulder and nerve damage as well. But both the ICAHO and the Ambrose really leaves us with a wide range of options as to what we should be doing with our radiation treatment fields. And as I mentioned, importantly, thinking about how the size of the lymph node involvement, as well as the number of involved nodes, and an increasing understanding of tumor biology, which from the systemic standpoint, medical oncology has been paying attention to for a long time, but in radiation oncology, I think we've been a little bit lax in incorporating that in our treatment decisions. And finally, as a radiation oncologist, I look at imaging a lot, both the pre-surgical as well as the post-surgical treatment planning CT, to really see and assess whether I think there's anything to worry about in the axilla or the supraclavicular region. So, okay, here's my question 2. I missed question 1, but we'll go to question 2, which was the case of a 45-year-old woman who was found to have a 2.5 centimeter grade 3 invasive ductal carcinoma, PR positive and HER2 positive, but noted to be in the lower inner quadrant, and she underwent lumpectomy and axillary node dissection with 2 out of 10 nodes involved. So the question is, how would you approach your radiotherapy treatment fields? Would you do radiotherapy to the breast only? Would you add the supraclavicular field? Or would you add the full axilla as well as the supraclavicular field? Or do you add the internal mammary nodes as well? So this moves to the two trials I mentioned that looked at patients who had had an axillary node dissection and really asked the question, should we add regional nodal irradiation to patients where historically they were thought to be of lower risk? So that is those with 1 to 3 positive nodes or those that are node negative. Everyone will agree that patients with 4 or more involved nodes are high enough risk that we should add regional nodal irradiation, but this was an area of controversy. And I will also comment that we're kind of stuck in the number of nodes, which I think is a little bit limiting because we know that a 5 millimeter node and a 2 centimeter node probably act very differently. But nonetheless, these trials were designed according to the number of nodes. So the first trial was the Canadian MA20 trial, and they included any patient with node-positive disease or, as they defined, high-risk node negative, which was a T3 tumor or a T2 tumor with adverse features of an ER negative, grade 3, or presence of LVSI. They were randomized to whole breast radiotherapy alone or whole breast radiotherapy and regional nodal irradiation. And this included the internal mammary nodes as well as the medial supraclavicular region. And remember, these patients did have a completion axillary node dissection, which would have included level 1 and level 2 of the axilla. And the medial supraclavicular field really also included level 3, which is the infraclavicular nodes. These patients were primarily node positive, but there were about 10% of them that were this high-risk node negative group. And at 10 years, in the New England Journal of Medicine, they presented their results showing what we all were expecting, a statistically significant reduction in the risk of local regional recurrences. But what we were surprised by was also an improvement in disease-free survival. And while it wasn't statistically significant, there was a small trend toward an improvement in overall survival. And here are the curves, where, as I mentioned, the isolated local regional recurrence disease-free survival results were not surprising, but the disease-free and distant disease-free survival in particular were quite notably striking, even though the curves aren't very big, based on some of the comments earlier in the day. In breast cancer, as you know, these numbers can be clinically meaningful. And yet, no difference in overall survival, but a trend favoring the use of regional nodal irradiation. As I mentioned, we all know in radiation oncology that we are impacting local disease and regional disease. We're very much like surgeons in that regard, but the impact on distant disease is quite interesting. And I think in breast cancer, it probably reflects the improvements in systemic therapy, that as we're seeing patients living longer with better distant control, that the impact of regional treatment, local regional treatment may make more of a difference. The subset analyses were also interesting in that while there is some generally favoring regional nodal irradiation, all subsets, the confidence intervals did cross 1, except in the group of patients that had ER negative and PR negative disease. With any treatment, of course, there comes toxicity, and they did see an increase in lymphedema risk, although I was surprised to see it as low as 8.4%. So it makes me wonder if they had underreported a little bit, because most of you have seen breast cancer patients will note that they notice some edema symptoms even before we can visually see anything. And they also noted an increase in grade 2 radiation pneumonitis. But fortunately, there was no difference in cardiac events, which is important when we're thinking about including the internal mammary nodes. The EITC 22922 trial was reported in the same New England Journal of Medicine issue. And this trial included node-positive patients as well. And the node-negative patients were those that had central or medially located tumors. And they randomized patients to breast or chest wall radiotherapy alone, or breast and chest wall radiotherapy with regional nodal irradiation, and similarly defined as the MA20, including the internal mammary nodes and the medial supraclavicular region, which also included the level 3 nodes. These patients, again, just to emphasize, did have level 1 and level 2 dissections. And this group actually was kind of split between node positive and node negative. And so the reason I highlight that is because for a long time in node negative patients, we didn't add nodal irradiation. And so this is quite interesting given these results. So the local recurrences were no different, which you wouldn't expect because both arms received breast or chest wall radiotherapy, but the regional recurrences were decreased with the use of regional nodal radiation, and very, very similarly to MA20, a decrease in distant recurrences. And here are the distant disease-free survival and overall survival curves. Overall survival, again, was not statistically significant, but trended in that direction, while the distant disease-free survival was. Both of these trials, and it's very similar to the other trials I wanted to highlight, were all accruing in the early 2000s, so really emphasizing, how do we incorporate them in the current era where we're using different agents, and I mentioned trastuzumab, but all the different agents, of course, that Dr. Pegram just talked about as well. And they were very similar in their results, and I think when you have two trials that say the same thing, from two different areas, Europe and Canada, it really makes you rethink how you're approaching these patients. So I've actually started to include internal mammary nodal irradiation a little bit more, which brings me to my next controversial topic. It's been an area of controversy because when you do design fields that include the IMNs, you do increase pulmonary and cardiac toxicity. The only randomized trial that looked at this specifically, that is, what is the individual role of the IMNs as it relates to recurrences, was a French multi-center trial. This trial randomized patients to chest wall and supraclav radiation plus minus IMN irradiation. And they included node-positive patients or these patients with central tumors. And they powered this trial to detect a 10% difference in survival. So that's one of the limitations that many people will criticize, is that they probably overestimated what they would expect to find. And not surprisingly, there was no statistical significance between the two groups in this trial. And so the curves very much overlapping. I remember reading this and kind of threw it away because at the time I didn't treat IMs very commonly, and so this data just supported what I was already doing, and so I didn't really pay attention to it. Until, interestingly, this publication last year from the Danish breast cancer group, where they didn't have a randomized trial, but what they did, their country decided that if you were node positive and had a left-sided tumor, you would get radiotherapy that did not include the IMNs because you wanted to avoid the heart. However, if you had a right-sided tumor, you would get IMN radiation. So it wasn't randomized, but we know that roughly 50% of the tumors are left-sided and roughly 50% are right-sided. And they did see, again, the separation of the curves doesn't look very big, but statistically, it was a significant difference in overall survival and a decrease in breast cancer mortality with the addition of with the addition of IMN irradiation in addition to the supraclav radiation. And very parallel to what we saw with MA20 and EITC, this decrease in distant recurrence. So it really challenged us to rethink the use of IMN irradiation, especially in the United States, where I think a lot of people shy away from that. And I didn't treat IMs very much until I started to see IM recurrences. And there are many radiation oncologists who will say, oh, well, we don't see IM recurrences very commonly, so we don't have to worry about it. But I think it's because oftentimes patients do go on to develop distant disease, and as a radiation oncologist, we may not actually see those patients who have IM recurrences unless they're isolated. So I think that looking at these data, IM nodal irradiation, and often it's prophylactic because patients don't have clinical or radiographic evidence of IM nodes involved. I think it may make a difference long term as we're seeing, as I mentioned, improvements in systemic control in other sites. So this is a subgroup analysis. It does, again, the confidence intervals crossing 1 on the patients with the medial tumors, but I also, looking radiographically at some of these tumors, especially MRIs, you can see this nice blood vessel going from the tumor down to the internal mammary nodes. So I think it's really hard not to look at that and think, maybe we might want to cover that area with our treatment as well. But as I mentioned, toxicity comes with this additional treatment, and pulmonary being one of them. And I, for the first time this year, saw clinically symptomatic patient with a clinically symptomatic radiation pneumonitis. Hadn't seen that before because I didn't treat IMNs. This patient happened to have a history of asthma. So now I'm very careful about looking at other risk factors the patient may have that may predispose them to increased toxicity. And of course, cardiac toxicity being significant so that we don't offset any improvements in breast cancer mortality by increasing cardiac toxicity. But with that, we do see improvements in techniques over the last few years. A lot of us are using deep inspiration breath hold, which I'll show you some pictures to illustrate. And also in treating the IMs, oftentimes we can just treat the upper IMN. So many times it's above the LAD and the left ventricle, which are probably more of concern in terms of long-term toxicity. So when we do our treatment planning CT scans, we not only get three-dimensional information, but we're also able to do a four-dimensional treatment plan, which is using gating. And what I mean by that is we can monitor the patient during their breathing and get images at various points in the breathing. So this is an example of a patient just during normal expiration, where you can see if we're treating the left side, the heart is butts very close to the area that we want to treat. During inspiration, you can see a little bit of separation as the expansion of the lungs separates the heart from the breast. But then when we have them take a breath and then hold it, the heart pulls down and away from the chest area that we want to treat. So we not only get separation, but we also get the LAD and the left ventricle even further away from the area that we're focusing on. So when we're looking at the internal mammary nodes, you can see if we're treating someone in a breath hold scan versus an expiration scan, that can make a big difference. So we're now incorporating these techniques to hopefully safely treat patients and gain the improvements with the use of IMN irradiation, but not increase their cardiac toxicity. I'm sorry, this is out of order, so I'll just move on. Finally, what do we do about patients who have nodal involvement who undergo neoadjuvant chemotherapy? This has also been an area of controversy because these are patients, had they had surgery first, they may have been eligible for MA20 or EITC, in which case we would say, yes, they would benefit from regional nodal irradiation. But now with neoadjuvant chemotherapy, if they achieve a path CR, it may potentially select out a group of patients who may be able to avoid radiotherapy. And this has really evolved. Terry Mamounis in the NSABP group retrospectively looked back at the local regional outcomes in patients treated on B18 and B27. These were trials that were randomizing patients to neoadjuvant chemotherapy or adjuvant chemotherapy. He, as a surgeon, was interested in looking at the local regional outcomes, and in particular, it's kind of hard to see, but I'll draw your attention. The yellow is your in-breast recurrence or your chest wall recurrence, and your blue is your regional recurrence. So these patients on NSABP trials all had either lumpectomy and whole breast radiotherapy only and no nodal irradiation, or mastectomy without post-mastectomy radiation. And what they found is that in those patients who achieved a path CR in the node, so it would be this group right here, we'll go back. The risk of a regional recurrence, so this little blue bar, and in this one it was actually 0, is very, very low. Can't get lower than 0. So the suggestion was, these patients who achieve a path CR in the nodes probably don't need post-mastectomy radiation and they don't need regional nodal irradiation. So this prompted the ongoing NSABP RTOG trial, which is enrolling patients who have documented nodal disease. They undergo neoadjuvant chemotherapy, and at the time of surgery, which they could receive a sentinel lymph node only, if they have a pathologic complete response in the nodes, they're randomized to whole breast radiotherapy alone or whole breast radiotherapy plus regional nodal irradiation. And this actually does include the IMNs. What's striking about this trial is that, first of all, in every trial you have a control arm and then you have an investigational arm. And when you ask different radiation oncologists which is the control arm and which is an investigational arm, you get different answers. Some people feel that the control arm is this whole breast radiation alone based on the NSABP data, and we're investigating the use of regional nodal irradiation as to whether that would improve outcomes. And others would say, well, they're node positive, and so we should do the regional nodal irradiation as the control, and we're investigating whether omission of that is safe and doesn't impact outcomes. So it's really quite interesting in talking to different people. So we're all eager to get these results. That being said, I was not able to enroll any patients onto this trial. And I was really surprised because I thought people don't like radiation, they're gonna wanna avoid it. Well, now you have node-positive patients, especially young ones, they want everything, and they're not safe, or they don't feel safe not getting that regional nodal radiation. So I was a little surprised, but it'll be interesting to see. It may take a while to accrue patients. There's another cohort on this trial that undergoes mastectomy, and that randomization is to post-mastectomy radiation or no radiation. And that's a little harder sell because that's kind of an all or none, and I think young, particularly young patients and the ones who are likely to achieve a PAS-CR are triple negatives or HER2, ER negative, HER2 positive patients. I was surprised also that they wanted the full thing and didn't want no radiation. So very quickly, if they still have nodal disease, then they're eligible for the Alliance trial, which is randomizing them to completion node dissection or no further surgery but comprehensive axillary radiation. So a very parallel design to Ambrose, but in the neoadjuvant setting. So just very quickly, how do we approach this then? We have to look at the size of the metastasis, the number of involved nodes, and the number resected, and also looking at the age and biology of the tumor. And as I keep harping on, the use of systemic therapy has really changed over time with the HER2-targeted agents, endocrine therapy recommendations that are now longer than they used to be, and also even in premenopausal women using ovarian suppression. And then chemotherapy, which was pretty commonly used in node-positive patients, is now sometimes not being used with the results of the MINDAC trial and the ongoing trials looking at the Oncotype. So I don't know how that's gonna play a role in terms of how we're approaching our radiation fields. And with anything, as I mentioned, discussing these risks with patients as it relates to lymphedema and pneumonitis. So probably it would be important over time to obtain some biomarkers so we could really figure out which nodal metastases are clinically significant. So just last slide is if I have a node-positive patient and they didn't have an X-ray node dissection, I think that's accepted now based on ACAHO, Z11, and Ambrose. But then I might consider these high tangents to cover level 1 and level 2 if I have some other risk factors depending on the patient. But if they have a lymph node dissection, if they have a macromet, depending on how many nodes in the biology, I might be more comprehensive like with Ambrose and cover the full axilla and the supraclav. And then looking at MA20 and EITC, I consider nodal irradiation in patients even if they've had a completion node dissection, but again, depending on some of those other factors. I've increasingly started using IM nodal irradiation more frequently, but recognizing that I have to individualize it and make sure I'm not causing too much toxicity. And then finally, after neoadjuvant chemotherapy, my bias is that we should use regional nodal irradiation until proven otherwise, but I recognize that that's controversial. And certainly if there's residual nodal disease, no one would argue that at the current state is to go ahead and offer regional nodal irradiation as well. So with that, thank you for your attention.